Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Mass General Cancer Center. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you can visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, co-host, and the guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to Devin Punch. She is the health educator for Mass General Cancer Center, and she will introduce you all to today's guest speaker.
Thank you, Amy. Hi, everyone, and welcome today. Thank you for joining us, and thank you to Lorraine for being here. Quick introduction to Lorraine before we turn it over to her. Lorraine is a nurse practitioner in radiation oncology at Massachusetts General Hospital. She holds a doctorate degree in nursing practice. She's practiced nursing for 40 years and oncology or cancer nursing for over 30 years. She has established and currently runs the Sexual Health Clinic for Oncology patients at Mass General Cancer Center, as well as in radiation oncology. And she has also established a sexual health clinic for women with gynecologic cancers in the country of Botswana. Thank you so much for being here, Lorraine, and I turn it over to you.
Thank you. Thank you, Devin and Amy, and thank you to the Blum Center for inviting me today. I'd like to start out with just telling a little story. I often get asked on how I came to get into this work, the work of sexual health. And this started many years ago, earlier in my career at Mass General. I would say over 18 years ago, I was a staff nurse in radiation oncology and cared for a lot of patients who received pelvic radiation. And I noticed that when they came back to see us, they had these effects that they just didn't expect and were very distressed about. But one story in particular really sparked my passion to do better. And it's that I had a young woman who was 42 years old who had received pelvic radiation, who within 2 or 3 years after her radiation, her vagina was closed and she required a hysterectomy. And I was devastated. The doctor who treated her was devastated. And I reflected back on her situation and her care. And at the end of the treatment, it was standard that we would go over an intervention program to help prevent some long-term effects of radiation. But when I looked back upon it at the end of treatment, people who receive pelvic radiation are exhausted. They often have very distressing bowel effects, and they may have some skin reactions, so they may hurt. And when I thought back about that, I thought, well, just maybe this isn't this time. We need to make this better. So I started looking and doing some more work in this, and we'll go over, and that's where I got to today. But that was a starting point for me that sparked a passion for me to do this work. So let's look at the statistics regarding sexual dysfunction in cancer. So 40 to 100% of cancer patients do experience some degree of sexual dysfunction. It's one of the most common concerns reported by cancer patients in a survey found by Lance Armstrong Foundation. And I can tell you through experience, it is much more common than I originally thought it was. Unlike many other cancer side effects, sexual problems, they commonly don't go away. And in this country, the prevalence of long-term sexual dysfunction is estimated to be at 50% or half for the 2/3 of patients who have been treated either for pelvic or breast tumors. So it really is a large population. So what's the difference between sexuality and sex? And I'd like to start out with who we are in terms of our sexuality, because that's the total expression of who we are as human beings. Begins when we're born, and it ends when we die. But it's like who we are when we look in the mirror, right? It's our body image, our gender identity, our role, even how we view intimacy, eroticism, our genitals, relationships, love, affection. But it also includes those values, knowledge, and behaviors of how we grew up. We're influenced by our families, culture, and society, faith, beliefs. And you'll see that as we go on, these are all things that when I work with people, I ask them about and I ask them permission to discuss. So if you compare that with sex, sex is whether someone's male, female, maybe they're gender neutral, or it's the act of having sex. So how and why was the Mass General Cancer Center Sexual Health Clinic established? Well, when you look at the setting of oncology, cancer patients, and in the literature, sexual health was a worldwide problem that wasn't being addressed. When I was in nurse practitioner school, and again, when I went for my doctoral work, I really got to explore the literature and saw that it was a problem on every continent, North America, Europe, Asia, Australia. There were all some common themes regarding sexual health after cancer and needing more intervention. So why do we have such a problem with this? Well, there's no education provided in medical school. And it wasn't in my program when I became a nurse practitioner. It's not in any programs. The other issue is if healthcare providers do ask patients about sexual health, and if they have a problem, what do we do when the patient says yes? So traditionally, there weren't a lot of answers. So in 2016, here at Mass General Hospital in the radiation oncology, one of my mentors, Dr. Jennifer Wu, and I did a sexual health needs assessment. And the purpose was to look at sexual health needs in patients. This was what we call the convenience sampling, which means whatever patients were coming in on certain days who were either receiving treatment or in follow-up, we would ask them to complete a survey on regarding this needs assessment. I did the lion's share of these surveys, and I have to say it helped me to be able to be more comfortable in asking patients about their sexual health. And lo and behold, 107 out of 109 patients completed this survey. So only 2 patients said no. One of the patients that said no to me ended up calling me 2 years later and asking me if I could help them with their sexual function. So there were 46 females and 61 males, and they were either under treatment or in follow-up. It was about half and half. 75%, or 3 out of 4, reported sexual health changes from treatment. 76% agreed or strongly agreed that they would be interested in hearing more in a multidisciplinary clinic or to a program that would address sexual health. The one thing that really stuck out to us in this study was patients who were in follow-up. So we're talking either 6 months or years after their cancer treatment reported significantly worse degrees of change and distress in their sexual health, and they expressed interest in a formal sexual health program. Now, I will say that sometimes when I initially talked to people and would bring this up, I would get some responses such as, I don't want to sound like I'm being ungrateful. I feel like I'm lucky to be alive. I'm getting my cancer treated. And it would take some convincing to let patients know that was no longer enough for us. We took a lot away in trying to cure their cancer, and there were things that we just wanted to give back to their quality of life. So what we found is, what do patients want? And I pulled this out of our study and out of the literature that's out there. Patients want their treatment team to initiate conversations about sexual health. They want us to appreciate the devastating effects that these unresolved issues have both on the patient as well as the partner. They want us to be open, honest, and reflective about their concerns. And they want us to normalize the changes and concerns so they know they're not unique. So for example, I do treat a lot of women who have vaginal dryness. This is a common issue across the board. It happens to women who've had radiation, surgery, chemotherapy, they're on hormonal therapy. But lots of times women don't know that when they first come into a visit with me. And that's one of the things I preface, is that this is such a common problem. The other issue is when I look at all women in the United States, and I have taken a look, there are over 40% of women in this country, whether they've had cancer, not had cancer, whether they're before menopause, after menopause, have pain when they have sexual intercourse, over 40%. And we could witness that by going into any drugstore or store that sells a lot of these feminine products. You see all kinds of lubricants, moisturizers. A lot of this information is even online. So it's a fairly big business. The problem is that common. The other important thing that we've learned is that patients don't expect their treatment team to be the experts, to know everything about sexual health, but they need a supportive place to talk, and maybe just a reference or a place to start. And the other thing that we always need to remember, our partners need support too. And I'm always thrilled when I see a partner come in with the patient on the sexual health visit, whether it be in person or in Zoom. It's always a really good visit. So what do we find? When should we as healthcare providers initiate this conversation? So I've quoted my colleague, Ann Cates, who is a well-renowned sexual health therapist nurse, oncology nurse as well, who I had the pleasure of being able to serve on a panel with recently. But she says assessing sexual health concerns should occur repeatedly along the treatment and survivorship trajectory, because patients have different needs for information and support at different times. And then we also have two of our cancer organizations, the American Society of Clinical Oncology and the National Comprehensive Cancer Network, of which MGH is a member. And what they've said is this issue should be raised with individuals at the time of diagnosis and should continue to be reassessed periodically throughout the treatment follow-up. The NCCN says ask about sexual function at regular intervals. So I wanted to look at what were some barriers to discussion. Why aren't we doing this routinely? So physician guidance for issues related to sexual dysfunction were inconsistent. And I looked at a study, this was a Dutch study, a very big study done in Europe. The common themes were there was a lack of time, that this was something physicians felt would take a lot of time that they didn't have. Again, physicians don't have training in this. They're not comfortable necessarily bringing this up. Physicians perceived that patients wouldn't like it and would find discomfort if they brought them up. And of course, the lack of experience. If they didn't have experience treating in this, what were they going to do when the patient said yes? So I'm going to talk a little bit about the conversation that I have, and I take these questions from Ann Cates. What, if any, concerns do you have about sexual functioning? What changes in sexual functioning have you experienced since diagnosis or treatment? And how satisfied are you with your sexual function at this time? And how has your treatment affected your sexual function? And I'll use any of these questions. And I also ask, I do a lot of working with our training with some healthcare providers as well. And all I ask is for them to ask one question. But this is basically a sexual function assessment. And this is one that I use in my practice when I work with patients. So what to expect at the sexual health clinic? So it's a nurse practitioner run program. The visits can be in person or virtual. I mean, when they're in person, we're in a private exam room, either the patient or the patient and partner. Virtually, I remind people that I am in an office all by myself. I have headphones on, so that it's a very private visit. Any documentation that is in the record is not listed under the sexual health clinic. It's listed by location. I am a provider in the radiation oncology department. So my notes, that's how they're listed, that a note by me from the radiation oncology department. Visits can occur before, during, or at any time following treatment. For our clinic, you just need to have a cancer diagnosis, and it's not certain kind of cancers. I've seen people with many, many different types of cancers, from brain cancers to pancreatic cancer, pelvic cancers, prostate cancer, breast cancer, gynecologic cancers, bowel cancers, many different kinds of cancers at different phases of treatment. Some who are about to start treatment, some who've been out of treatment for several years, some who are considered cured of the cancer, some that cancer is a chronic disease for them. But it doesn't, there is no, it's the cancer diagnosis is the only criteria for coming to the sexual health clinic. Clinical appointments consist of an assessment, and we go over a health history, as well as a sexual health assessment, education, support, and some visits, intervention, whether it be medications or vaginal dilators or anything along those lines, moisturizers, lubricants. And I just want to stress, privacy is always very important during this time. So this is just a theoretical framework that I use, called the implicit model. They use it a lot in social work and mental health, but I like to use it, and I also ask that providers, when they ask patients, to use at least one or two of these. So things like permission, like invite the patient to enter the discussion. So I'd like to review with you how, if you have any sexual health issues, and put it out there, helping people to be able to talk about it. Limited information. So what we do is we talk about how normal it is for these things to happen and the percentages that they happen in cancer. We make some specific suggestions. At the limited information point, a provider may refer to me, and I would do the assessment and offer some specific suggestions, or refer someone to a more intensive therapy from a sex therapist if that's needed. So what are some of the specific sexual problems and changes that patients and their partners face? We're going to go into this part of the program right now. So first we'll start with treatment changes in men. So men can have neurovascular changes resulting in erectile disorder. And this can be from chemotherapy agents, radiation surgery, as well as hormonal therapy as well. There's endocrine changes with hormonal therapy. They have decreased testosterone. The libido is often decreased. They're also at risk for osteoporosis and the vasomotor hot flushing, as well as infertility. I will preface that when a man starts treatment and they already have some erectile dysfunction, it may likely get worse during this time. Other effects that happen are fatigue and decreased physical stamina. These are areas that I explore a lot. If someone is experiencing a lot of fatigue, they often don't have a lot of libido or desire. And male children treated for cancer can either experience delayed puberty or not experience puberty at all from all of these changes. So when we look at radiation for prostate, bladder, or rectal cancer, they pretty much will experience sexual dysfunction. I have to say, I really haven't seen men escape at least a little bit of dysfunction. Men who are younger and have fewer health problems have a better chance of having very minimal erectile dysfunction. And again, if erections are affected prior to treatment, they're less likely to return to normal. Androgen deprivation therapy also really contributes to both erectile dysfunction as well as low desire. Prostatectomy is another factor as well. So other physiological changes in men that if men come into cancer with these issues, they can compound the issue of erectile dysfunction. So if they have, if they're overweight or obese with a high BMI, if there's a history of smoking, which can affect vascular changes or circulatory changes, alcohol, diabetes, high blood pressure, and heart disease. They're all contributing factors to erectile dysfunction, whether a man has cancer or not. So some psychological changes that we see. Again, less desire for sex when they have low testosterone levels. More difficulty feeling pleasure with touch, and this is especially seen with the androgen deprivation therapy or Lupron therapy. Men often don't, they notice they don't, even just the touching sensation is just not the same. Depression and anxiety, whether it be from erectile dysfunction, when pelvises are radiated. Sometimes there's some bowel accidents during the treatment or shortly after. Men who may have a bowel cancer, men or women, may have a colostomy, and that creates a lot of anxiety and a whole different set of issues along with sexual dysfunction. So treatment changes in women. There could be side effects of treatment, such as joint discomfort, neuropathy, hair loss, all very distressing. Acute or premature ovarian failure. So what that means is if someone has a cancer where they need to have a hysterectomy or their ovaries removed, they will go into an earlier menopause. As without the ovaries, women don't make estrogen. So that can happen acutely. It can cause a lot of distress. Surgical scarring, lymphedema, which is the swelling that can occur in the arms of women when they've had axillary lymph node dissections and radiation to those areas so that they need a sleeve or some type of compression. Changes in appearance and changes in sensation. I do hear from a lot of women who've had mastectomies with implants placed, or that they wish they knew more about the changes in sensation in advance, because the changes, the sensation in the chest is changed forever. And this is very important and distressing to women who found that their breasts were a neurotic area with a lot of sensitivity. So we'll talk a little bit about the consequences of ovarian failure. There are vaginal alterations. So what that means is that the lining of the vagina is more fragile, it's more dry. A lot of times the natural pH will change. Vasomotor symptoms can happen, and that the vagina does have muscles, so there can be muscle spasms that can happen whenever there's any type of penetration, making it feel like it's painful or blocking. Infertility, osteoporosis, hot flashes, and mood changes. Along with the vaginal alterations, vaginal dryness is very, very common. And again, I've seen it across all women with different types of cancers, women who've had different types of treatments, including surgery. It's a very, very, very common issue. Natural menopause versus premature ovarian failure. So a natural menopause for women, the average age of menopause for women in this country is 52. And usually there's a phase where women become perimenopausal, and then there's a gradual change to menopause where they may be getting their menstruation less and less, with the definition of menopause as 1 year total with no period whatsoever, no menstruation. So there's that versus premature ovarian failure when someone was a woman could be premenopausal, totally having regular menses. There's a hysterectomy, the ovaries are removed, and all of a sudden there's nothing. There's a sudden hormonal shift. There can be intense mood swings. There can be very intense hot flashes and sweats as a result. And then there's also estrogen is protective for women in terms of osteoporosis. So when women who are younger, have premature ovarian failure, they're more at risk for these other changes of osteoporosis to happen. Fatigue and decreased physical stamina. Fatigue is a common problem, and it can be related to treatment. It could be related to not sleeping well. It could be related to life, to working, caring for a family, and trying to recover from cancer treatment. So long-term vaginal effects in women. So the vaginal dryness, which when women go into menopause, this can get worse over years. We talked briefly about the vaginal muscle irritability, which the formal name for that is vaginismus. A narrowing of the vagina, vaginal stenosis. Specifically, this happens with women who've had pelvic radiation. Direct tissue damage to the genital area. So this could be surgery or radiation as well. Pain with sexual intercourse. So the medical term for that is dyspareunia. And again, I've seen this happen with surgery, radiation, chemotherapy, across the board, hormonal therapy especially, anti-estrogen therapy. Orgasmic dysfunction also can happen where women either can't have orgasms or it takes a very, very long time for them to have an orgasm. Worse overall sexual functioning, and again, permanent ovarian failure. If a woman has pelvic radiation, that will automatically, they'll automatically go into a menopause from that, unless for some reason there was time in they were young and the ovaries were moved out of the field. If they're in the treatment field, there's permanent ovarian failure. So again, other contributing factors are physical health, fatigue, if there's any pain, and these are all important to know. Bowel or bladder issues, I do especially go over these. If people are having distress over bowel issues or bladder issues, they're not thinking much about sex and how they're going to be able to have sex. These issues need to be worked on first. Neuropathy, which is a decrease in sensation, which can be in the fingers, the feet, but definitely distressing in hands if you want to touch your partner and be intimate with your partner. Definitely very distressing. And effects of medications. So we always go over a list of what they're taking that could possibly be contributing. Sometimes some of the antidepressants contribute to a decrease in libido. And then there's the psychological health. There's depression, fear, there can be relationship issues. All of these can contribute to a woman having desire. So the impact of long-term treatment effects. So the incidence of vaginal stenosis and dyspareunia in women who've had pelvic radiation can vary from 12 to 88%. I have to tell you, I see it more on the higher side. I see way more than 50% happen. It's a common issue in women who've had pelvic radiation. Several longitudinal studies found sexual dysfunction issues for patients. They continue for at least a minimum of 1 to 2 years post completion of radiation therapy, and they can be long-term. For men, erectile dysfunction can always be there. For women, the vaginal dryness, I don't see that turn around for them. Vaginal stenosis, we can work on minimizing or preventing, but I don't see the vaginal dryness turning around unless patients have been on a long-term program where they are providing moisture for these issues. So I wanted to just switch gears a little bit to talk about adolescent and young adults of a population that really could use a lot more research as well as intervention. So looking at their sexuality and sexual functioning. So the aspects of developing our sexuality and sexual function are all part of who we are in terms of developing in the age 15 to 39 age group. 15 to 39, that's the adolescent young adult. That's the definition. Cancer can alter or delay these tasks, but it doesn't remove them forever. They still will go through them. And they often have very little experience to draw on to cope with the effects of cancer on these important developmental tasks. So by that, I mean the young women who may engage in sexual intercourse for the first time and find that it's not pleasurable at all, that it hurts, it's uncomfortable, and she doesn't know what the big deal is. With no frame of reference, with no teaching, the young adult population doesn't know this. Sexual health issues for those ages 15 to 25. So when we look at dating, there's a lot higher incidence of casual hookups. They need to be reminded a lot of safe sex and sexually transmitted diseases. Often they need to be counseled regarding reliable methods of birth control. And again, they're unable to compare the before and after if cancer happened to them before they ever started dating. There's often feelings of isolation, loneliness, worries of being unlovable or unattractive. I've heard comments sometimes, it's like, I'm damaged goods, who's gonna want me? And those feelings are there a lot. Sexual health issues for ages 25 to 39 and dating. Unmarried men in this age group outnumber unmarried women. There's often challenges in finding a committed relationship. Women in their 20s and 30s who are cancer survivors are less likely to marry when you would normally expect them to marry. And there's a lot of fear that their new partner may be turned off by any physical changes. That a potential life partner may worry that they're going to have their cancer come back or maybe even die. That they may not be able to please a partner sexually or not experience sexual pleasure themselves. And if there's infertility, they may not be chosen as a partner. So these are all the issues. And here at MGH, we are in the process. I'm very excited to hear that we are in the process of developing a program for the adolescent young adult population that desperately needed more and more of these programs. So I wanted to put up my wish list that I've worked on over the last 5 years. So I'll start with my doctoral work focused on developing a sexual health clinic in oncology. I did the pilot program was my doctoral project, and then it turned into a clinic in radiation oncology. My department ended up being very supportive, saw the need, and then went over to the cancer center. So that's been the trajectory of how this has evolved. But you know what? I can't do this all by myself. There needs to be lots of resources. And over the years, I've gotten more people to discuss it. So that's your RN, NP, PA, and MD. They're now discussing it and offering resources. I have pelvic floor physical therapists that I refer to, social workers, sex therapists. We have some wonderful sex therapists now here at Mass General. And I have gynecology and urology resources that I refer to. We also have some online resources and support groups. I'm working on that a little more, but recently I have been invited to a few support groups where we've talked about sexual health. And my goal is one day to be able to have a support group. So over time, I've been able to get there on my wish list. So some tools and resources. So these are some resources from some of the professional organizations. This is ISHWISH, is the International Society for the Study of Women's Sexual Health. This is all women's sexual health, but a lot of the common problems that patients with cancer experience, they deal with, they also do have a component to help women who have a history of cancer. The Scientific Network on Female Sexual Health and Cancer is a wonderful network that there's several of us in Boston who are on this network. They have a lot of education, both for providers and for patients. I mentioned before the American Society of Clinical Oncology. They have patient information as well as provider information, and the National Comprehensive Cancer Network. And for our men, we have the Prostate Cancer Foundation is also quite the foundation that helps men with erectile dysfunction. The Anal Cancer and HPV Foundation also exists for patients who have HPV cancers. One of the cancers that I have not discussed here that we are looking more and more at in terms of assessing their needs and trying to help are the patients that experience head and neck cancers, who in terms of sexual health, you may not think what you mean by sexual health, but having a dry mouth, not being able to taste and kissing someone, or having cancer where it can be visible, people can see you, and you may believe that you're disfiguring. So this is another population that we're also looking at. So just to talk a little bit about, I'm going to touch on management of some of these problems, only because there's often a lot of different interventions. So one of it is to have what we call penile rehabilitation, which could be sexual excitement either from self-touch or with a partner. But for men who have some erectile function, the medications, what we call the PDE5 inhibitors, can work quite well. Those are Viagra, Cialis, Levitra. I tend to give patients patient prescriptions and ask them to go on the GoodRx app, because these can be expensive depending on what your insurance coverage is. Or they can go on the GoodRx app and then tell me where they want the prescription sent. But again, these are good medications for men with erectile dysfunction, but there does have to be a little bit of erectile function there. If erectile function is absent, these medications have been shown not to work. Other alternatives are penile vacuum pumps. These can be obtained all over the internet, and they are a therapeutic device. They can range in cost from starting at about $50. And this is just an example of one here. An aerobic exercise and healthy lifestyle helps circulation, and circulation is important in the pelvic area. Penile injections, the Cabeject, and penile implants. I have a urologist who specializes in erectile dysfunction that I send these patients to. The Cabeject, the penile injections, you have to be certified to be able to prescribe those, and the urologists are, and they do a great job with this, as well as the implants. But there's a lot of ways to be able to be sexually active. So interventions for women. So for dryness and pain with sex, there's science, there's studies that we follow on this. And first line treatment are your over-the-counter products. There are tons of these. And my recommendation always is, if you go into the drugstore and you buy one and it doesn't do it, find another one. There's different consistencies for the lubricants in terms of how thick they are, or how moist they are, how comfortable they are. And usually I recommend that both partners use them. It creates comfort during sex with both partners. Second line treatment are vaginal or topical estrogens. These come in both tablets as well as creams. I find that if women have a lot of extreme dryness, the creams are better. And I know that women who have a history of breast cancer do wonder, estrogen receptor positive cancer, do wonder about these, but they are shown to be safe. And I know that I work closely with the breast oncologist here at MGH in Newton Wellesley, and they've given blanket approval to be able to prescribe these if they're necessary. Third line is a medication called Osfema, not covered by a lot of insurances, and I would say it's a minimum of $60 a month, and it's something that a woman can try daily to help with dryness. I haven't used it yet, but it is out there, and it is there are some specialists that are being used. Other studies that are going on are with DHEA, progesterone. Those are two progesterone type medications the progesterone is converted into intracellular estrogen. But it doesn't raise the serum estrogen level. So it's very promising, and I'm looking for more studies, but it actually may be safer with the history of breast cancer. Not recommended at this time are the progesterones and the Mona Lisa procedure or the vaginal laser rejuvenation. So I do get asked about this a lot. This is accessible through gynecologists or actually even through some plastic surgeons. There's two things about this that I don't recommend. We had no long-term data for a while, so that when women came to me, I said, we don't have long-term data. I had heard some good things about it, but I mean, long-term data, we like to see data that's over 10 years old. Recently, though, there's been a study that has shown that one study that there can be some scarring. So right now, I'm not recommending this for women, but it's a very common procedure that's out there. There's a lot of information out there. For decrease in libido is always very challenging. And again, I like to do a thorough health history, because if someone's not sleeping well, if they're fatigued, if they have any bowel issues, if they're having a lot of hot flashes, these are all contributing factors to having low libido. With androgen deprivation therapy, one of the medications, Lupron, this is used in both men and women. I've seen a lot of people on Lupron. I haven't seen anyone not affected in terms of libido. Libido is definitely lower. So some of the interventions are sensate focusing exercises. These were first developed by Masters and Johnson back in the 1960s, which involve, it's actually a program of exercises, activities that you do with a partner, where one partner would have their eyes closed or a blindfold, and the other partner would do the touching. But there's ground rules, and the ground rules are that you cannot start out by touching someone in a sexual area. So no chest testing in the breast area or the pelvic area, in those areas, and you can't have it lead to sexual intercourse. So those were two of the ground rules, and it's sort of a progressive exercise over a series of weeks. But sensate focusing, if you Google it, you will be able to find it. Romance. I often ask patients, I ask women especially, what attracted them to their partner in the first place? What was it about them? What were things that they liked to do? What was their favorite date night that would put them in the mood? Was it watching a romantic movie, or going to their favorite place for dinner, or during COVID, having their favorite place deliver dinner? But any activity that would put them in the mood. Vibrators for women, they are therapeutic. And I am a proponent of vibrators and encourage women to use them if they want to use them. I'm sorry, I'm saying a lot and I don't mean to. Over 40% of women don't have orgasm with penetrative intercourse. And this is all women. This is not just women who've had cancer treatment. And they have orgasm with clitoral stimulation, external stimulation, either by vibrator, manual, foreplay, other forms of sexual interventions that they have. So something else to remember, they can be therapeutic. Vaginal dilators are I actually have them for patients. They're silicone, the ones that I have, and they're a vaginal intervention they're two purpose. So for women who've had pelvic radiation, they minimize the vaginal stenosis. They keep things from narrowing. For women who have that vaginismus, those muscle spasms, these are the treatment for the muscle spasms. They help that muscle irritability and help induce relaxation of the muscles. Regular sex. Sex is very good for you. It enhances blood flow to the vagina, enhances blood flow to the penis, but overall sexual activity is good for you. And I do encourage patients to go back to sexual activity when they can. And we already talked about this, an orgasm before intercourse. Having an orgasm before intercourse is often very helpful. It helps relax the muscles and that air in the pelvic area. So let's look at medications for low libido. Flibanserin and bremelanotide are for premenopausal. They have a lot of restrictions. I have not prescribed them. ASCO says that you can use the flibanserin now, but I have not used it. And the bremelanotide has a lot of restricted uses in cardiac disease. Recently saw a very promising study that showed that bupropion or Wellbutrin is an off-label use for low libido. So it's nice to know that we have that option as an off-label use. In studies, testosterone is currently shown to be effective, but there's no long-term data. But when you have to look at the risk with testosterone, if you have any type of coronary artery disease, it can increase the LDL and decrease your good cholesterol, your HDL as well. It can cause acne, hair growth, and weight gain. So there's a lot of pros and cons, but something that I don't use because again, there's no long-term data. Some take-home points that I have for you. Information regarding long-term sexual effects should be given to you. And if someone doesn't ask you about them, it's fine for you to ask them. And it's an important thing. So I would encourage you to be proactive. Although we hope your provider will ask you a question, again, we just said this about your sexual function, be proactive, ask them about any potential changes in sexual health. And a lot of times for patients who are giving a consent, going over an informed consent process, these may be listed. It's okay to stop and ask your provider to give you a little bit more information about what those sexual effects are that can happen during treatment. Receive education regarding sexual dysfunction if possible. And you can receive resources or a consult for a sexual health visit. There's lots of information out there around Mass General in terms of being able to have resources. I just put up some resources here in the Boston area. The massgeneral.org, cancer, sexual health, and fertility, as well as the Dana-Farber across town also has a program. These are AYA specific resources as well, again, also important. And that's the end of my presentation, and I would love to hear from you in terms of questions.
Thank you, Lorraine. You certainly provided a lot of information. We do have a couple of questions that have come in that I can start to pull up here. You did mention several different specific types of cancer. Are there certain types where someone is more likely to experience sexual problems, or is it kind of dependent upon?
Sure, that's a good question. So in terms of, I guess if you're asking where I would expect it to happen, in breast cancer, in prostate cancer, anyone who's had hormonal therapy, anyone who's had pelvic radiation, I would definitely expect them to have some sexual dysfunction issues. But it can, again, chemotherapy also, there's different chemotherapeutic agents and regimens that can really cause a lot of vaginal issues for women, erectile issues for men. And anyone who's had hormonal therapy, if anyone is on any type of hormonal therapy, I would expect for them to have sexual issues.
You talked a bit about topical estrogens. do those help with desire, or do they just address dryness?
They're topical. They just address the dryness. They're not, and that you bring up a good point though. There's the hormone replacement therapy, which that's out of favor. We would not, I would not prescribe hormone replacement therapy. And in most cases, I know breast oncology would not agree in most cases. You'd have to have a gynecologic oncologic specialist, I think, try to see if the benefits of that would be worth it.
Are there any vaginal lasers that are safer than the Mona Lisa?
There's different, I haven't heard that any are safer. There are, you're right, there's different vaginal lasers. There's also, there's thermo, like a thermoablation type procedures as well. But again, there's no long-term data on them. So right now the jury's not out. I am not recommending any of them.
If someone is being treated at a different cancer center that doesn't have a sexual health clinic and they're noticing problems, what would you suggest that they do?
I would start with their oncologist, their medical oncologist or oncology NP, because there are resources. There may be resources in another area. There are online resources. There may be gynecologists who might be able to help. And I guess even as a patient, you could initiate that yourself, going to a gynecologist or a urologist if you're a male, and see what they have to say first.
And you talked a little bit about fertility. What steps can someone take to preserve their fertility before treatment? And what does that entail exactly?
So that entails referrals. You need time to do that. I refer them to the MGH and the Fertility Center here, which is in the Yawkey building, so that they can, for women, it could be preserving eggs, egg retrieval and preserving eggs. And for men, there's a New England sperm bank, and they can definitely donate sperm to be frozen and preserved. The process is much quicker for men than it is for women.
You did include some resources, but are there other organizations or resources, websites that you might recommend in terms of sort of partners communicating with one another around sexual health needs?
Specifically, I mean, I think all of the ones I put in there do address both. Have I seen specific ones just for partners? I have not. In terms of just for partners and sexual health, but as you bring up, it's a real issue. I know some of the things that I've experienced with couples are how does the partner go from being a caregiver, helping someone get through treatment, back to being a partner and a sexual being again, with that sexual relationship, and trying to having the person who was the patient getting control again, taking over those things and getting back together as the couple. Often some sexual health therapy, going to a therapist, helps kind of get there.
Thank you for that answer. Couple of questions about the sexual health clinic that you run. Do you see patients who are in remission? And for in-person visits, are you based in Boston?
So yes, I see people at any stage, as long as they've had a cancer diagnosis at some point. That is the only requirement. I am based in Boston. At this time, I don't have privileges anywhere else, but I can do virtual visits for patients who are, and I have done them. I see a lot of patients from Newton Wellesley Hospital as well, some from Emerson. So virtual visits I can do from those areas, but if not in-person visits, I am based in Boston.
And is a referral needed?
You can self-refer. So no, I mean, if you talk to your oncologist or other physician, recently I got a referral from a gynecologist at Newton Wellesley for a patient, but it doesn't have to be. I have patients who find me on their own and make an appointment. They take down the phone number, or they go through Gateway and they find where they can make an appointment.
And how do you handle virtual visits if someone lives outside of Massachusetts?
I cannot see anyone who lives outside of Massachusetts. I am sorry.
We do have a couple more minutes for questions if there are any more coming in. It looks like we do have one here. If you have tried estrogen, but it's not working for dryness and irritation, should you try other brands of estrogen, higher doses, or more frequent use, or what should someone do?
So I'd like to I like to stay with the lowest dose of estrogen possible, especially if they've had breast cancer. So I do hear this often. So we'll talk a little bit about vaginal estrogen. So how do you take vaginal estrogen? It starts out with what we call a loading dose. You take it every night for a week, but then you can't take it more than twice a week. What I find is that women often need an over-the-counter as well. They use the estrogen twice a week, but they might need an over-the-counter moisturizer. There are tons of vaginal moisturizers out there. And I know I didn't talk about them in great detail, but if you went online, you could put vaginal moisturizers. They are different than lubricants. Some of them have hyaluronic acid. That's two of them, Hylogyne, Reverie. Those are two products you get online. They had prospective studies that showed a small benefit for women, but there's two. There's a website called New Eve, NEU-EVE, where the owner of this company is a chemist who underwent breast cancer treatment and had vaginal dryness. And this is a company that has suppositories as well as other products. So there can be suppositories, creams. If you wanted to go and look in a store, make sure it says moisturizer versus lubricant. So a long answer is I would use an over-the-counter moisturizer in addition to the vaginal estrogen because you're limited. It cannot be used more than twice a week for vaginal estrogen.
Thank you, Lorraine. Looks like we're just about to run out of time here, but I'm just going to put in the chat box if you would like to schedule an appointment, the phone number, and if not, you can visit one of the radiation oncology front desks. So
Sure.
putting that in there as well from our
or
website.
or if they're in the cancer center, I think there's stuff posted around the cancer center. I've seen it. Or you can ask your nurse practitioner, a medical oncologist there. Thank you, Devin. Thanks.
Thank you, everyone, for joining us today. We hope that this was helpful for you. And again, thank you, Lorraine, so much for being here and sharing your expertise.
Again, I thank you so much to all of you and to the Blum Center for allowing me to present today. Appreciate it.
Thank you so much. And as I had mentioned earlier on today's session, if you're interested in viewing the recording of today's program, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. I would give it about a couple of weeks, but it'll be posted there. Thank you so much, everyone, for joining us today. Hope you found today's session helpful and have a lovely rest of the day.
Thank you.